I'm going to be joined by the presenters today, and your reward for staying for the Q&A is you'll also hear from CMS, and two CMS representatives who haven't yet been to the podium are Joan Proctor, I'm sure many of you know, is a national coordinator for Home Health Quality Reporting Program, and Terry Mata will also be up here with Stace Mandel, Ann Olson, and Ann Spinard. So they've reviewed the questions that were submitted. Thank you very much. The first question is related to proper interpretation and completion of OASIS C2. The source has always been OASIS Answers, who compiled all questions nationally. The proposal to send questions to each state OEB is concerning, as all states will likely receive different guidance. Also, for national agencies, this may be difficult to follow or access. Is there a proposal for a central repository? I can now read the answer, and please know that this is in consultation with the faculty. All questions related to the ongoing availability of information through the OASIS Answers contract should be directed to Janine O'Malley at CMS. Her email is janine.o'malley@cms.hhs.gov. The second question was the combinations of assessments and their relationships to the assessments are not in the download slides. Could you please post them? And per Nicole Keene, who presented today, the Home Health Quality Reporting Program page has a section called Determining Provider Compliance with Home Health Quality Reporting Program Requirements. If you scroll down on that page, all 7 scenarios are posted there. The next question, where do we find our compliance percentage?
Yes, we actually send out quarterly for you a report that provides a sort of a synopsis of how you're performing to date, which there's actually, if you look on the spotlight page for the home health, CMS section of the home health quality reporting page, you'll see a link. You click on that link and it'll take you over to how to go and assess what your individual performance is like. So you should be able to monitor that, and nothing should be a surprise at the end of the reporting period.
Thank you, Joan. Next question that was submitted. How will the removal of the potential avoidable events affect the survey process? The response that was drafted was, again, all questions related to survey and certification issues should be directed to Janine O'Malley at CMS. And she has the next as well. The question submitted was, how is CMS going to assure consistency amongst responses from the OASIS education coordinators on similar content areas? And again, the response was to direct questions to Janine O'Malley at CMS. Next question, if episodes are excluded, if missing data for covariates, will a patient with M1028 blank, because the patient does not have the 3 selected diagnoses, is that patient excluded from the measure?
As we said when we went through the slides, in that question, it is possible to leave it blank if the patient does not have PAD, PVD, or diabetes. It is not excluded because it's left blank. It's simply saying that the patient does not have any one of those 3 diagnoses. So the answer to that question is no, it would not be excluded. But it is on you and in your agency to make sure that your auditing process is such that it's not both boxes left blank in error, but because, in fact, the patient does not have those diagnoses.
Does missing data come from marking a dash on M1313?
So, we talked about this. You can use dashes, but they should be used rarely. And usually in the 13, 11, 13, we know what we're dealing with. So it would be a rare exception that you would use a dash. If you used a dash, that would be missing data for that, because you didn't have the data to put in. But I would imagine that we really are not going to see that too often, but it is a valid response. You can do it, but it would be considered missing data. You didn't have it.
When a patient has diabetic PVD or PAD, are both items checked parenthetically as yes, even though these are combination E codes and no I code is included?
Again, I would refer you back to the slides. It listed in answer to the E code, it said that you would be looking for a diagnosis that began with the E and the 3 digits, I believe, 173. And for PAD and PVD, the 170.2 all the way up. And so you are looking for those codes. That was the information that was on the slide so that you can go back and use that as a reference.
Next question. Some experts are teaching that in M1311 row 2, you are to look to see if the current pressure ulcer was at the same stage as at SOC. If not, it would not be counted in row 2. Is there guidance to support that? The guidance says how many were present on admission. Does that mean present as a wound or present as a wound at this stage? That is different from the old column 2 guidance.
Okay. So the first question is, how many pressure ulcers does the patient currently have at whatever stage? So let's say stage 2. So you would code that number. And if if any more than 0, the second question asks how many of those were present at the start of care. So it's not like the pressure ulcer on Ann Spinard's right elbow, okay? It's looking at how many stage 2 pressure ulcers, and then it asks the question if you have, more than 0, so 1 or more, it would say how many of those stage 2 pressure ulcers were in fact present upon admission. Hopefully that answers that particular question.
Thank you, Ann. Does the instruction to code based on assessment as close to admission as possible mean that if the ulcer is unstageable on day 1, but debrided? Thank you. Debrided on day 2, do we still report it as unstageable at SOC and leave it?
So the answer to that question is yes, coded as to the initial assessment. We've heard some other questions around this impacting potential payment for wound care and whatnot. A couple of people have asked that question, so we've asked them to put it in writing, and then we can respond to that at a later date. But the guidance that we're trying to do, and again, you have to understand that we are looking at this across all of the post-acute settings, the 4 post-acute settings, and the guidance given to everyone is on the initial assessment, and including scan. Whatever you find at that point, that's what we would like you to code on the OASIS.
If the stage 3 pressure ulcer present at discharge was a stage 2 pressure ulcer at admit, is the response to B2 a 0 or a 1? Is it the same stage or the same pressure ulcer?
Okay. I just want to make sure I have which question we are. Okay. So the response to B2 is 0 based on the stage 3 pressure ulcer not being, oh, wait a minute, is this, which question were you asking? I'm trying to think, this one? This one here, okay. So again, I think what we're hearing from this particular question is, again, we're looking at the number of pressure ulcers present upon admission and then at discharge. It's not following that one ulcer, unless that's the only ulcer the person has. But we're looking at any pressure ulcer on the person's body and what stage they were at the start of care, and then we're looking at the number of discharge pressure ulcers at a particular stage. And then the follow-up question to that, and this again is saying, if I have 2 stage 2 pressure ulcers on discharge, the second or the follow-up question is, how many of those stage 2 were present upon the start of care assessment? So it's not, think of it not as just following that one pressure ulcer, unless that's the only one the person had, but the numbers, and then asking how many of those were present upon admission. So hopefully, again, that answers that question.
Next question. If we are supposed to assess the condition of the ulcer on admission and it is now better than in a previous facility, why would we code it based on what it was instead of what we currently see?
Okay, got that. All right, I guess I should just stay up here. Good question, but so we talked about that, the fact that we don't reverse stage, right? So hopefully people got that throughout the education or the couple hours that you had. If it was a stage 3 or stage 4 and it looks like it's a stage 3 now when your clinicians are examining it, again, go back to looking at the transfer paperwork and all the information that you have. And if it said it was a stage 4, it is a stage 4 until it closes. So that's just, you got to make sure your clinicians know that. Because knee-jerk reaction for the clinician is, oh, look at it, stage 3, boom, they just like done. Without going back and saying, was it always a stage 3? Or was this a stage 4 and is in the process of healing so it appears like a stage 3? So hopefully that answers. Good training point, really good opportunity to educate your nurses.
Thank you for submitting these questions. I assume this came in through the website, and I will read it verbatim. Historically, we've been told that we can't watch the wounds heal, and that if the patient/caregiver is independent in wound care, and the wound is, it should read, wound is significantly healed and appears healing, will continue without us watching it. We need to discharge the patient. But in this scenario, since we can't downcode, we would be discharging the patient with a healing stage 2/3/4 ulcer, but it would still be present even though our documentation supports that it is very small and superficial as the final layer of skin is granulating over the wound. Are we now expected to stay in the home until the ulcer is completely healed?
This is one of those issues we were talking about earlier that we are actually going to go into consultation with the payment policy staff for home health, where I used to work, and discuss an answer across so that we know that all the settings are, both sides of the program are talking off the same page. So we will be publishing a response to this question in a future update to the training webpage where we'll put it out there for everyone. But the truth of the matter is that there is an impact on payment. We acknowledge that, and I am aware of that.
Thank you, Joan.